This slide just kind of sums up what we were talking about in regards to medication administration, insulin administration, just about proper insulin storage, dose preparation. And it's really important to assess our patients, their specific handicaps, which may create a barrier in administering the correct amount of insulin. Are they able to see the labels carefully on each bottle of insulin to make sure they're administering the correct type of insulin? Those are huge in regards to patient safety and preventing those complications, especially of hypoglycemia. Do they have enough syringes on hand? Do they have a disposable box to use it as a waste to prevent injuries from the syringes after they use them? To be sure they're not using them a second time or a third time. Do they have proper blood glucose monitoring, enough strips? Are they doing it correctly? And all these infection control measures. Never lending out your glucometer to some other diabetic, because the hepatitis virus can live on a machine if any blood gets on that from another person. And again, in just a few minutes we're going to talk about diet therapy. Are they monitoring their diet, and are they adhering to it and not kind of going out of the spectrum of what they should be on and giving themselves extra insulin, so they're kind of allowing themselves to eat extra carbohydrates or sweets or simple sugars that may kind of make their blood sugars very erratic. These are kind of things that we definitely need to make sure our patients have that foundation of knowledge to keep them safe and prevent them from coming into the hospital with some serious hyper or hypoglycemic problems. All right. This topic is absolutely huge in regards to glucose control for our patients who are diabetics. I mean, obviously, what they eat plays a significant role in managing their diabetes, because there are also associated variables with diet, especially if we've got someone who exercises a lot. That's going to burn up more calories. Or do we have a person that has to lose weight, for instance, a type 2? So all that will be taken into account as to how many calories we assess that patient to incur on a daily basis. And this is just kind of a rough formula of what our patients who are diabetics, and also can give us non-diabetics a great guideline in keeping our weight under control and allowing us to only eat a certain amount of calories to be healthy and to prevent excess calories and causing us for weight gain. Protein intake of about 15 to 20% of the total daily calories, with obviously normal kidney function. Carbohydrates about 45 to 65%, and those can include fresh fruits, vegetables, whole grains, legumes, and low-fat milk. And thinking about dietary fat and cholesterol, reducing to prevent cardiovascular disease, 20% of which only 10% can be saturated. And then, of course, fiber. Improves carbohydrate metabolism and lowers cholesterol. And the American Diabetic Association really encourages about 25 to 35 grams per day to help stabilize blood sugar. And sometimes that might be too large of an amount initially. When someone starts to add more fiber to the diet, it can cause them a little GI distress, causing them to develop a little diarrhea and abdominal, pain and gas and things like that. Sometimes they might want to start on a lower grams per day and then just kind of work up to a larger amount, preferably 25 to 35 grams. So those are things that you want to think about. And we look at foods in regards to nutritional therapy as the glycemic index, and that's the term that's used to describe the rise in blood glucose levels after carbohydrate-containing food is consumed. And these all should be considered when a meal plan is formulated for an individual who has diabetes. Now, can you use sweeteners? It usually is fine as long as the glucose is controlled. And let's talk about alcohol. It does affect blood glucose. Now, normally, alcohol is a carbohydrate, but we count it as a fat, and it does affect blood glucose. You should always ingest alcohol with or shortly after meals to prevent problems with hypoglycemia. It can be substituted for 2 fat exchanges when calculating caloric intake. When we talk about the amount of calories a person should have, we want to think of the exchange system. 1 carb exchange equals 15 grams of carbohydrates. And so when we're talking about insulin coverage, we can kind of use the formula 1 unit of regular insulin for each 15 grams of carbohydrates that's consumed. That's kind of the rule of thumb. And we used to use the food pyramid, but the new food for thought, excuse the pun, is a plate method, which kind of shows you how much of that plate should consist of, fats, carbohydrates, proteins. So that's something that we may want to teach our patients, which may be a little bit more simpler than to teach them the whole concept of the food exchange. If you go to the website myplate.gov, it will show you how much of a certain food should be a portion of your meal. Obviously, vegetables probably are the largest, with your grains and proteins, and fruits are the smallest along with dairy. It's kind of an easy way to kind of determine and make food choices for patients, and obviously we need to consider if they have some significant health history, have already been diagnosed with cardiovascular disease. And again, calories are very much based on age, sex, height, weight, and even someone's physical activity level. Obviously, we're going to start eating foods that are low in saturated fat, low in sodium, and also foods that have less of those added sugars. Focus more on whole fruits, vary your veggies, making half your grains whole grains, and then making half your plate mostly fruits and vegetables, and then vary your protein routine. And again, not only do we want to eat the right amount of foods, but we want to also, keep hydrated with the right type of fluid intake. And when we look for a diet plan for our type 1s, we'd like to see correlating eating patterns with insulin onset, peak, and duration. And obviously the meals, the snacks, and the insulin regimen should be based on a person's lifestyle. So for instance, if someone who's a type 1 works nights, obviously we're going to work around the times when they're awake, and when they're working, and their sleep patterns. Snacks are very important in relation to the amount of timing of exercise. And obviously the availability of foods are based on occupation, financial, religious, and ethnic constraints. And when a person is self-monitoring their blood glucose levels, it helps the patient make adjustments for their planned meals or any changes in their routine. Okay, then we look at the type 2s. Are we looking at that person and considering, do they need to lose weight? We encourage consuming meals of equal size, maybe 4 to 5 hours apart. with 1 to 2 snacks, and obviously a decreased fat intake. Many of these patients with type 2 diabetes, remember, they pretty much follow that metabolic syndrome, so a lot of them will have high cholesterol levels. So in regards to the choices of food that they make, we are hopefully trying to bring those lipid levels down, and then obviously assessing their specific HDLs and LDLs. So, those are things that, we're looking at when we're looking at type 1s versus type 2s. And again, making sure that when we're planning these meals for a diabetic, that they are ingesting proper new vitamins and minerals, meeting energy needs, achieving and maintaining a reasonable weight, and really to avoid those fluctuations in their blood glucose. And really to, keep that blood glucose in control, which really prevent later on developing any macrovascular disease as well as microvascular disease. Maybe patients that are overweight, that are obese, may have to decrease their daily calories by 500 to 1,000 calories in a day, and that really gives them an ability to lose safely 1 or 2 pounds a week. Okay. And really learning about reading food labels, understanding the nutrition values on those food labels, looking at carbohydrate content and sugar content, and obviously calorie content. Looking at foods lowest in calories and fat and highest in fiber should make up the basis of their diet. Okay. And then again, looking at foods that may have some of those artificial sweeteners. Sometimes sorbitol may cause patients, and even other patients who are not diabetics, more of a laxative effect. Okay. Remember, some of your foods that may be sugarless or sugar-free may also have a lot of calories. Okay. And again, stressing the importance of how to teach someone to drink an alcoholic beverage, whether or not it's 4 ounces of wine, a beer, or maybe some kind of other liqueur. It's most recommended that it's 1 drink for a woman and 2 drinks for a man. And it's very important that when they do intake alcohol, that it's not done without food, because it really puts someone at risk for developing hypoglycemia. And again, talking about the exchange system, and this is where with meal planning, it's kind of a great thing to bring in the dietitian and obviously provide information that is easy for that particular person to understand, along with the family, especially the wife or the husband who does the cooking, who does the grocery shopping. And again, the food pyramid that we're talking about is more nowadays as myplate.gov, looking at the food plate, rather than that pyramid that we used to go by years ago. And this is just a way in which we may count calories. Ideal body weight times 10. We factor in their activity level. We may increase by 30%. If they're sedentary, increase 40%. Moderatively active, or increase 50% if very active. For instance, a young adult, maybe 150 pounds, and depending on their level of activity, may need 1,950 calories a day. But if they are a person that needs to lose weight, then we would decrease those calories by 10%. And that's the healthy way to lose it, by 1 to 2 pounds a week. And always look at, the food labels in regards to sodium content, especially if you've got someone who does have a history of blood pressure problems. Maybe they are on some medications to control that, but more sodium, and remember, sodium likes to be friends with water, and that's why it will bring more vascular volume on board, thus increasing blood pressure. And hyperinsulinemia is a chronic high blood insulin levels that occur with intense treatment schedules and may result in weight gain. Sometimes these are people that really become more insulin sensitive, and these patients may need to treat their hyperglycemia by restricting calories rather than increasing insulin, because sometimes, you know, their blood sugars are so high and we just keep giving in more and more of that insulin. And remember, I said that we become insulin resistant if we're giving more than 200 units of insulin in a 24-hour period. And we can prevent weight gain by giving the patient more of a prescribed meal plan, really teaching them about regular exercise, and avoiding overtreatment of hypoglycemia, not to really, you know, pounce them with a lot of simple carbohydrates or sugars to get that blood sugar up. And then sometimes we then treat it again with insulin, which they may become very insensitive to, or sensitive to, and not bring that blood sugar down. Let's talk about exercise, okay? Because this is a really big part of not only a diabetic lifestyle, but obviously should be very much a part of ours, even for people who are non-diabetics. Exercise does have a lot of benefits for anyone, and especially with the diabetic patient. It's an essential part of a diabetic treatment plan, and there are a lot of great benefits to exercise: better regulation of blood glucose, lowering of insulin requirements, and increases insulin sensitivity, and also helps in regards to someone's cardiovascular health, increases circulation. But there is always a risk, especially for your type 1s, where they have more of a risk of hypo or hyperglycemia, and there should be precautions used before someone who is diabetic begins a exercise program. You know, if we've got somebody who's, you know, in their 40s or 50s, or has just been diagnosed as maybe a type 2 diabetic, we wouldn't want to say, hey, okay, go on out and start, you know, jogging 2 miles a day. Some of these people really need to be assessed for any kind of underlying cardiovascular problem, and maybe if the person has not exercised in a very long time, we would encourage them to, you know, start out with maybe just walking, you know, a half a mile, and then just, you know, increasing that distance as one becomes, you know, becomes in better shape to be able to tolerate the activity level. We would never encourage anyone to exercise, especially a type 1, with no prolonged exercise unless glucose control improves. We would really always like to encourage more a moderate type of exercise, and depending on when they are given their insulin, we would never want them to exercise during peak time of that insulin, because that's when they'd be most likely to develop hypoglycemia. Maybe right before they're going out to exercise, they should always indefinitely monitor their blood glucose to know what their blood sugar is before they go out and exercise. And if it is borderline normal, maybe they would want to have some kind of food, simple food, before they go out and exercise to prevent any problem with hypoglycemia. And again, depending on their hydration level, to be sure that they're taking in proper amount of fluids. Maybe the type 1 diabetic may take a carbohydrate source or a drink an hour before, maybe an hour after exercising, to prevent any type of hypoglycemia from occurring. Type 2s, again, diet, exercise, and weight loss, again, assessing their health status before initiating an exercise program, and then providing them guidelines for exercise. Needs to be planned to prevent hypoglycemia, and also definitely carrying that fast-acting carbohydrate in case they're out walking or away from the house, where they have that on hand that they can adjust it quickly if they notice that they're starting to have signs and symptoms of early hypoglycemia. There's a lot of benefits to exercise. Obviously, helps with blood pressure control, triglycerides. It's important that diabetics follow, warm up and stretching, and then maybe a cool down for about 5 to 10 minutes after exercise. The recommended amounts of exercise is about 150 minutes per week, and maybe 3 days a week. No more than 2 consecutive days without physical activity. Okay. With your type 2s, obviously their problem is insulin resistance, and this helps to improve better utilization of glucose uptake, maybe to start out walking, making sure they have good shoes, and not to exercise in any extreme cold or heat, to make sure they're properly hydrated, and don't exercise within 1 hour of insulin injection or at their peak. Patients should be monitoring blood glucose before and after to kind of see how the effects of exercise have affected their blood glucose, okay? Because this will give them an opportunity to see if they need to increase their food or also increase fluid intake, okay? Along with aerobic type exercise, some of your patients may want to also include muscle strength with low impact weights or aerobics. But again, the importance of exercise is to make sure that they're monitoring their glucose before and after. So the time when they perform their exercise should be scheduled in relation to diet and to insulin peak. And with that monitoring, if they have a blood glucose that is over 220 milligrams per deciliter, obviously they would check ketones. And if there's ketones present, then, and along with this 220 blood glucose, they would not exercise, because what this tells that person is that their blood sugars are not in control. And again, monitor blood pressure to assess for any renal or cardiovascular diseases. Okay, so these are really important guidelines that we really try to encourage our patients to follow to prevent any of the complications, particularly hypoglycemia. And, when we, encourage exercise, we want to hopefully have our patients who are diabetics find an exercise the patient will enjoy, proper footwear, along with inspecting feet daily, avoiding those extreme hot and cold temperatures, and really avoiding exercise when maybe their blood sugars aren't really under good control, okay? And we would not want them, especially our type 1s, who really starting to have frequent bouts of hypo or hyperglycemia, should avoid prolonged exercise until we can get their blood glucoses back on track, okay? And again, when we talk about a carbohydrate, a simple carbohydrate, if they're out exercising and they start developing any signs and symptoms of hypoglycemia, we need to, explain to the patient what those types of simple carbohydrates would be. Your book gives you some samples of that, maybe 5 or 6 lifesavers. What else can they give? A simple sugar drink like pop, orange juice, something like that, that would cause an increase in their blood glucose quickly, okay? So be sure to refer to those charts that will kind of help us teach our patients about what we mean by a simple carbohydrate, something that's easy to carry with them when they're exercising, because they definitely want to have that on hand when they start to feel signs and symptoms of early hypoglycemia. You also have to consider patients that might already have some of the macro or micro vascular problems on board. Think about your patients that already have some of the retinal problems that I discussed earlier. You sure wouldn't want them to be doing something like lifting very heavy weights or really partaking of a very vigorous exercise activity, because this could further cause vitreous hemorrhage or retinal detachment. And we do see our patients also that, already have arthritis and some of the neoplasms and infections and things like that. So that's all taken into account when we encourage them to start some kind of a exercise routine, okay? Think about those non-bearing weight exercise such as, swimming or bicycling. And again, considering where their insulin is administered, we want to avoid the appendage that the insulin is administered in, because with exercise that will cause the insulin to be absorbed more rapidly, and that could cause your patient to develop hypoglycemia. The last bit of information that I'm going to talk about is the sick day rules. I think people get a little bit concerned when they start to get sick and they're thinking to themselves, what do I do if I'm sick? What happens if I have the flu and I'm on oral anti-diabetic medications and I can't keep anything down and I start vomiting? What if I'm on insulin? I'm a type 1 diabetic. Should I continue to take my insulin even if I haven't been eating a lot because I've been very nauseated or having GI problems? And those are very, very good questions that the diabetic may have. And we're all going to get sick, and our diabetics are no exception. So these are the things that we need to talk to our diabetics about. Answer the questions, what if I am sick? When a diabetic is sick, even with just a cold, the blood sugar may rise. And why does that happen? It's because of those body-releasing hormones that fight infection, which result in the increase in blood glucose in our patients, and makes it harder for insulin to lower those blood glucose levels. So that's why it's very important that we talk with our healthcare providers, if you're diabetic, to develop a plan for sick days to help in controlling the blood glucose, preferably upon diagnosis, especially upon a diagnosis of diabetes. So the first thing you might want to do is, when you are sick, is to notify your healthcare provider of your illness upon onset. If you're on any oral diabetic medications or on insulin, we want you to continue taking these medications and continue injecting yourself with insulin as long as you're continuing to monitor your blood glucose every 4 hours. And notice how frequent we are asking the diabetic to do that, because then we can keep a good grasp on exactly what a person's blood glucose is when they are sick, okay? If by some chance, as they are monitoring these blood glucose levels, that the blood glucose is over 240, we then want these patients to check for ketones. And if we see ketones in the urine, then we're definitely sure that the blood glucose is not really in good control. And usually if over a 24-hour period that the blood glucose still is very high and we're still seeing ketones, we would definitely call the physician, because maybe he'll have to make adjustments in your insulin or whatever medications you're on. Obviously, if you're seeing ketones, this is for somebody who is probably a type 1 diabetic. Maybe, the guideline is 2 hours, but maybe if the blood sugar is continuously high, the physician may recommend that you monitor your blood glucose every 2 hours. The important thing is that you do not become dehydrated. We want that person to continue drinking enough fluids, preferably 8 to 12 ounces of liquids every hour while you're awake, okay? And to really watch your intake and your output. Are you not drinking much? Are you becoming very dehydrated? And how much are you urinating? You want to follow up with your healthcare provider if you have moderate to large ketones or you're still unable to keep anything down. These kind of things will prevent the patient from developing a problem like diabetic ketoacidosis, okay? You might want to write down and keep a log of what your blood sugars have been over the last 24 hours, especially if you're monitoring every 4 hours, and then if you're even increasing that to every 2 hours, okay? When you're drinking fluids, it's important to drink more of the sugar-free fluids to prevent dehydration. Get a lot of rest. Don't stress yourself. If your temperature is really very high and continues to be high over a 24-hour period, say for instance a temp of 101, call your physician, because that's a most likely reason why a person will get severely dehydrated, have changes in blood pressure, which can definitely affect perfusion, which can definitely affect urinary output as well as your cognitive functioning. So the question is, what do I do if some of these things occur? When do I call my physician? If you really do have persistent nausea or vomiting, if you have moderate or high levels of ketones detected in the urine, if your blood glucose elevation is still high after 2 supplemental doses of insulin, if you have an elevated temperature of 101 or higher for more than 24 hours, if your blood sugars are higher than 240 for more than 24 hours, if you really can't tolerate any solid food intake, and even if your illness lasts more than 1 to 2 days, these patients are a group of patients who are at severe risk for developing DKA. So that's the kind of stuff that we really want to teach our patients about, and that we don't take any type of illness, even something like the common cold, very lightly. Because with diabetics, they can get into problems and have definitely a higher risk of developing DKA. So just wanted to make sure that you understood that, and that this is exactly what you should be teaching your patient. The last thing I'm just going to talk about before I end this lecture is surgical management. And some of our patients who are diabetics may have the capabilities of having a transplant of the pancreas, which would definitely eliminate the need for insulin. When they are candidates for a pancreatic transplant, they will be on lifelong immunosuppressant medications, and they previde your patients from developing like rejection of that particular organ, but they can also have some toxic side effects. Many times patients who need a pancreatic transplant may also need a kidney transplant, and many times they'll do that kidney transplant and a pancreatic transplant at the same time. Some of the surgeries will involve a whole pancreas transplant, and this surgery has been much more improved over the years, and there is a 1-year survival rate that is above 95%. Obviously, the pancreas is a organ that has been received from a cadaver. There's a lot of measures taken into play to prevent rejection and to decrease the risk for infection. A lot of complications are the side effects that occur from the immunosuppression drugs, abscesses, pancreatitis, and thrombosis. There's also what we call an islet cell transplant, which can eliminate the need for insulin and protect against the complications of diabetics. It could be a limited supply of beta cells, and we know our beta cells are the ones that provide insulin and amylin. With any type of surgery, depending on what is precisely needed for each individual patient, we want to promote good wound healing, prevent the to encourage the absence of infection, maintain normal blood glucose levels, and prevent those higher risk of complications. That's all I'm going to say about this, but I do want you to know that this surgical treatment for patients who are diabetics is out there. Tomorrow in class, we will talk about how a patient who is diabetic is surgically managed while they're having some kind of operative procedure. So I hope this helps, and we can conclude with the rest of the PowerPoint and talk a little bit more specifically about our proper foot care, about wound care, chronic pain, and then looking at DKA and HHNS, and really looking at how these complications manifest and what's the treatment, and how our patients can avoid this very serious complication in the future. Any further questions, we will discuss these in class. Again, thank you for your attention and have a great night.